Good evening, sir.
Good evening, Kamachi. Some of the presenters are here. So I think
Dr. Soundarya,
Soundarya is
be
not
discussing.
there. Whoever is present, they can start.
Myself presenting, sir. Shobika.
Dr. Shobika wants to start. Okay.
Yes, sir.
Good evening, respected professor and my dear students. I welcome you to another session of DNB online academic activities of RAISA. Today we have four ward rounds related topics. Now Dr. Shobika will present the topic on anesthesia for daycare surgery, isn't it?
Yes, sir.
Yeah.
Yes, sir.
Over
Thank
to
you, sir.
professor and Dr. Children. Thank you.
Yes, sir. Good evening, sir. My topic is on daycare surgery anesthesia, sir. Daycare surgery is defined as surgery for which a patient is admitted and discharged on the same day. There are some significant disadvantages in daycare surgery, which includes reduced nosocomial infection risk, reduced mortality and morbidity, reduced waiting list, reduced hospital stay, and it is more economical. Few examples of daycare surgery includes cataract surgery, squint surgery, dental procedures, tonsillectomy, laparoscopic female sterilization, lap cholecystectomy, circumcision, cystoscopy, carpal tunnel release, and local excision of breast. Prerequisites of daycare surgery includes limited duration of surgery, low risk of anesthesia and surgical complication, minimal blood loss, minimal physiological derangements, minimal post-op pain. Pain should be easily treatable with oral analgesics, ability to resume and feed in immediate post-op period. Patient selection criteria is based on social factors, medical factors, and surgical factors. Social factors includes patient must understand the procedure and consent to have it performed as daycare surgery. Post-surgery, patients should be looked after by a responsible person for the next 24 hours, and their home circumstances should be appropriate for post-operative care. Patients should reside within 1 hour of medical facility and should have telephone access. Should be refrained from a patient should be refrained from driving, operating heavy machinery, and decision making during the recovery period. Medical factors where ASA 1 and 2 physical status patient is preferred. ASA 3 can be considered if systemic disease is well controlled. Anyone with an unstable medical condition isn't suitable for daycare surgery. A difficult airway, sleep apnea, obesity, previous adverse anesthesia, allergy to be considered. In surgical factors, surgery should not carry significant risk of major complication, nor should it require prolonged specialist care or observation. Now, minimally invasive surgery techniques should be employed. Should be possible to control pain with oral medications or local anesthetic techniques. Patients should be able to resume normal function quickly and should be able to mobilize before discharge. Anesthetic goals in daycare surgery includes rapid induction, prompt recovery, early discharge, minimal side effects, and minimal pain. Anesthetic management. Preoperative assessment should ideally be done before the day of surgery to reduce cancellation and maximize efficiency. Effective pre-op assessment ensures that appropriate investigations are ordered and necessary protocols are implemented, such as fasting guidelines, administration of regular medication that the patient is on, and informed consent to be obtained. Uh, Anesthesia for daycare surgery includes general anesthesia, regional anesthesia, local infiltration technique, monitored anesthesia care, sedation, or combination of these. Type of anesthesia chosen will be influenced by surgical requirement, patient-specific consideration, experience of anesthetist, facilities, and personal who are available. Pre-medication with anti-anxiety drugs, prophylactic antiemetic, and antacids to be considered. Anesthesia should ideally be in rapid in onset and offset and confers minimal post-op nausea, vomiting, dizziness, and drowsiness. Short-acting anesthetic agents are preferred. IV induction agent, propofol is preferred. Preferred inhalation agents are sevoflurane and desflurane. Preferred neuromuscular blocking agents are cisatracurium and atracurium. Preferred opioid is fentanyl or remifentanil. In regional anesthesia, low doses and low concentration of local anesthetic agents with added neuroaxial opioid can be used. Providing good analgesia is important. Multimodal approach of paracetamol, NSAIDs, local anesthetic should be employed. It is important that oral analgesia is started before the local anesthetic wear off. In post-op nausea and vomiting, it is a cause of unplanned admission following the daycare surgery. Minimizing the starvation times and use of IV fluids can decrease the risk of post-op nausea and vomiting. At-risk patients should be given prophylactic antiemetics. Coming to recovery and discharge, there are 3 stages of recovery in daycare surgeries. First stage, the initial stage lasts until patient is awake, productive reflexes have returned, and any immediate pain on waking is well controlled. It takes place in recovery area with trained staffs. Regional anesthesia with no sedation will bypass this first stage. Second stage, this stage ends when patient is ready for discharge from the hospital or day unit. It occurs in an area near to theatres so that the staffs are able to contact both anesthetist and surgeon with any concerns. In late recovery period, the final stage of recovery, this is the final stage of recovery, which is complete following the full physiological or psychological recovery from the procedure. This can take weeks or months. Criteria for discharge includes stable vitals, and patient should be conscious oriented. Patient should be able to tolerate feeds with minimal post-op nausea and vomiting. There should be minimal pain and minimal bleeding at the surgical site. Caregivers should have adequate understanding of discharge instructions and should be able to provide basic post-op care to the patients. Patients should be advised not to drink alcohol, operate machinery, or drive for a period of 24 to 72 hours. Barriers to daycare surgery. There are 7 main barriers to delivering the effective daycare surgery, which includes economic, regulatory, educational, facility design, local home, community support, information, and organizational. Economic barriers. There may be financial incentives for either the hospital or surgeon associated with inpatient stays. Regulatory barrier. National legislation may block a shift towards daycare surgery. Uh, Educational, medical students and doctors may not be trained in benefits of daycare surgery and so may lack motivation to drive change. Facility design, health facilities may not be structured to favor the development of daycare surgery. Local home and community support, there may be lack of adequate community services to support the change. Information, patient and healthcare providers may not be aware of daycare surgery as an option. Organizational, effective daycare surgery requires strong multidisciplinary team working, and this may be difficult to achieve. That's it, sir.
Okay. It's more or less all the points have been covered, but this could be organized. These last few points about the organization, the setup, that could
Yes, sir.
be spoken initially before you start with the patient selection
Anesthesia.
and then
Okay,
anesthesia
sir.
management. First, how
Okay,
to
sir.
organize a daycare, that will be a better way of presentation. So what are
Okay,
the
sir.
types of daycare units you know
Sir, hospital-based daycare is there, sir,
of?
and standalone unit,
Mm.
office-based, and hospital integrated, sir.
Yeah, so that also can be mentioned because there are
Okay.
different types of daycare units that are presented. And then what what sort of planning or design you require for a daycare unit? Is it like
Sir,
your regular hospital where you will have a registration, admission counter, then going to your room, then coming to the OT, then going to your PACU, then going back to the room and then get discharged, or is it modified
no,
from
sir.
the regular hospital setup?
Yes, sir. So we'll have a reception area, sir, and then
Mm,
we have a changing room. A patient
mm,
will get changed there, and then will be shifted to the OT theater, sir.
mm.
And then from there, the recovery unit, sir.
Yes. So there are
That's it.
not much of many rooms available to admit the patient unless they
Yes,
develop
yes.
some complication. There will be 1 or 2 rooms to keep them. What if they develop any complications and require, you plan it as a daycare procedure? For example, you plan a lap cholecystectomy as a daycare procedure.
Yes,
Unfortunately, the surgeon cuts the bile duct or cystic duct gets injured and there is a massive bleeding and it has to be converted to open. In such case, what is the provision that you have to provide?
Sir, we have to admit the patient, sir. We have to convert into inpatient
So that point
care,
also
sir.
has to be mentioned. What are all the limitations of daycare surgery also have to be mentioned.
Okay, sir.
That not all
Yes, sir.
cases will be admitted in the morning and discharged in the evening. So
Yes, sir.
possibilities of extended stay, you should have provision to admit them in a hospital with reliable monitoring, and post-op complications have to be managed well. And obesity, originally it was thought of as a contraindication. But nowadays, what are the criteria to accept obese patients for daycare surgery?
Sir, if the patient, if we can do it under regional, obese patient can be done under regional blocks, sir. If we are going to give peripheral nerve block, if we are not going to manipulate the airway. If at all we are manipulating the airway, we should ask for the history of sleep apnea, sir.
Very good. So any patient with sleep apnea or severe sleep apnea which has gone on to produce pulmonary hypertension, right ventricular strain, and all those features, or patients with anticipated difficult airway, or patients who require surgery which may develop a complication, all these patients have to be properly assessed and eliminated from including in the daycare list. Okay, that is a very important point here. Otherwise, for example, obese patients coming for a inguinal hernia or an umbilical hernia, which can be managed, as you said, under regional technique, can very well be accepted, provided they don't have the other complications of respiratory problem or airway difficulty. So that is all. What about patients on insulin? Diabetic patients on insulin, can they be taken up for daycare procedures?
Sir, ideally, patient on insulin we don't take for daycare surgery, sir.
Supposing they have only a hernia, a patient on insulin has an inguinal hernia, or he has a varicose vein which requires a stripping.
Then we can monitor the sugars, sir, and we can stop insulin on the
Wherever
day of
oral
surgery.
intake can be resumed soon after the surgery, those patients, even if they are on insulin, they can be accepted for daycare surgery. That is a very important criteria. The problem will come only when the patient has to start. For example, you do a laparotomy in a diabetic patient who is on insulin, where you cannot resume until you get the bowel sounds or bowel activity. There you have to depend solely on insulin for controlling the blood sugars post-operatively. And that requires a special trained nurses, or the attending doctors should have some idea about how to control the blood sugar. They should have some idea about what insulin to administer. So in such cases, it is not advisable to go ahead and do the procedure in the daycare setting. On the contrary, a patient coming for a superficial procedure who is on insulin, where they can resume oral intake and go back to their home regimen of whatever medications and the doses of insulin they are taking, they can be very well admitted. That is the answer that you have to give in the exam if they ask you about how to, what is the criteria for admitting patients with on insulin. Okay, so it depends on how soon the oral intake can be resumed, so that the fear is not to trip them into hypoglycemia. That is our most important goal. A bit of hyperglycemia is always safer. So the teaching and concept is still the same, where err on the hyperglycemic side and not on the hypoglycemic side. That is the dictum that you have to. What about patients with cardiac ailments? Supposing a patient has a pacemaker or a stent, or has undergone SEABG 5 years, 10 years ago. What about those patients?
Yes, sir. Yes, sir. If the patient doesn't have any recent symptoms, less than 6 months MI or any CAD history, we don't take for daycare surgery, sir. But if the patient is well controlled and patient is clinically stable, we can take them for daycare surgery.
Take them for daycare surgery. Okay. So like that, you have to apply individual conditions of the patient to select whether they are fit for daycare procedure or not. So for that category only, for that purpose only, we have surgeries classified into minor, moderate, and severe surgeries. Okay. So the minor surgeries include cataract, some of the plastic procedures like liposuction or skin nose correction, and water removal, the daycare procedures like circumcision. All these things come under very minor procedure where minimal investigations and minimal requirement of anesthetic will be there, and that can be done under the daycare procedure. Then you classify them into moderate, then more intense surgeries. And as you rightly said, the restoration of normal physiology should be as early as possible after the surgery. That is a very important criteria for selecting the patient for daycare surgery. So this is, I will just show you a presentation where you will get a better